Welcome to the Resilient Performance Podcast. This is Keep It Real Talk number 5. We figured it out, Trevor. Last time we had no idea what it was. I think it was 4, so this is 5.
Good.
We had a couple questions come in recently from our course or from, just other people sending in questions from listening to our podcast. One was about, just wanted to talk about hip impingement, so we can go over that. And I think it's very relevant to a question we got from somebody who's on our course, recently bought our course and had a question about the biomechanics of hip rotation when you're going into squatting, change of direction, really anything athletic, any of the gym movements we can talk about, and why we're looking for hip internal rotation, adduction with some of these things, and then why we might want pronation at the foot, I'm assuming they're talking about in the question, as well as, and then relating that to knee valgus, right? Because that's always something that's a common thing that we hear at our course is, being worried about ACL tears or knee valgus when we're trying to improve femoral rotation, specifically hip internal rotation or adduction, because that's sort of just lumped into like knee valgus, which isn't really what we're going for. And it's actually, we would say, if you're lacking rotation and adduction, you would have probably more knee valgus when you need to access certain movement patterns on a field or court or whatever it is. But how do you guys want to start this off? Anybody want to just take the mechanics? We can talk about how the femoral head's moving real quick and just keep it general. We don't have to go too crazy with it because it is more of an audio format, but whatever you want to do.
I think for hip impingement, a good place to start is kind of to define it, obviously, but hip impingement, it's a real thing, right? But I think like a lot of other things in medicine, it doesn't matter until it matters. So what I kind of mean by that is, all right, like how we're defining hip impingement, how it's defined medically is, you've got a bony approximation between the femur and the acetabulum. And then, whether it's genetic or depending on the stresses imposed on that joint, you get increased bony overgrowth either on the acetabulum, on the femur, or both. And that would be whether you have like a cam lesion, pincer lesion, mixed. And then, that bony approximation and laying down more bone on either of those, on those sites can create symptoms in the hip, usually a pinching sensation. And then I guess, I actually don't even have the how the different degrees of impingement are classified, but I would imagine that the more bone that's laid down, that would be considered a more severe impingement. And a radiologist or orthopedist is going to have their own definition based on like what they're looking at on an X-ray. I mean, we're as physical therapists focused more on the functional aspect, but I mean, as we know now, because of the increased utilization of imaging and the increased sophistication, that hip impingements are more common now with that labral tears. Now, are they more common because they're truly more pervasive, or is it because we're looking for it more? Probably a combination of both, but I think it's more than likely, if we have to pick one or the other, it's because we're looking at it more. And like anything else, the more you look for things, the more problems you can find. So I say it doesn't matter until it matters, because we get a lot of people that have been diagnosed with FAI or hip impingement based on an X-ray or an MRI. And a lot of times it's a very like fatalistic diagnosis. It's like, well, you have these bony changes, therefore like, what's a general, you shouldn't squat below 90 degrees, or there's all kind of things that you shouldn't do based on that X-ray. And like anything else in medicine, the imaging should correlate with the clinical symptoms and the subjective findings. So a lot of times like people, they have a pinching sensation with deep hip flexion or internal rotation. They have a bony change on an X-ray, and then it's like, well, based on these two things, you shouldn't do X, Y, or Z. But it's very fatalistic, because if you have FAI on an X-ray, and like, let's say a big thing is like that rock back test. You do a rock back test, and it's like, now this should be your squat depth. It's like, okay, well, why do we even have a job if we're saying, you do a rock back test, and now you should, externally rotate your feet, make your knees wider when you squat. It assumes that like that can't change. Right. And that's why I said it doesn't matter until it matters, because with the right interventions, you can get somebody with with bony changes on an X-ray and MRI to squat deeper, regardless of what that rock back test is. Another thing is like, okay, you put somebody on their back, you have them internally rotate at 90 degrees of hip flexion, they get 0 or 5 degrees, and it's like, oh, this is really bad. But like that can be changed, and that's why I say it doesn't matter till it matters, because until you try stuff, you don't actually know if that FAI and the X-ray is meaningful. Like if you can elicit changes, if you can get somebody to squat deeper, or if you can improve their internal rotation, if you can improve their their squat depth, whatever, and not increase their symptoms, then it's just a label. It's not a true diagnosis. So to me, FAI only matters if the only thing that's going to help somebody is to shave off that bone, to change their anatomy. If you can get somebody to squat deeper, improve their IR, improve their symptoms, improve their quality of life without surgery, then FAI really isn't the diagnosis. It's something else. It's motor control, it's soft tissue influences, it's technique. And so we get a lot of people, right, where we don't even do a rock back test because I think that it's meaningless.
But based on your blog, no one really should bother, right?
Right, and we do.
You gotta put that to bed.
We should put this in the notes because I'm gonna write it better than I can say it. But like, if you have somebody squat with an anterior load, like a goblet squat or a zercher, and they can go to full depth without any pain, then did they truly, like, was the bony anatomy, was that really the driver, like the true pain generator or the true thing that needs to be addressed clinically? So there's so many things that can influence things like squat depth and internal rotation, not just your anatomy on an X-ray, because that anatomy on the X-ray is just a snapshot in time, just like that rock back test. It's a little bit more of a dynamic snapshot, but it doesn't account for all the things that can influence the relationship in that joint. So I think that, we hear a lot of things about like, here's how to determine the best squat depth. Do you have Scottish hip? I think like the amount of people now that have been told they can't squat because of Scottish hips now, it's like, I get that we have to respect anatomy, but I think now it's been kind of used as an excuse to not know what you're doing clinically. It's like, oh, they've got a Scottish hip, they've got FAI, like they shouldn't squat, when like, what should make physical therapy a valuable profession is that like we can have people do what they enjoy and get them to squat or do certain things in spite of that anatomy. Or obviously we're not trying to, jam somebody into a deep squat if they have symptoms. And there's certain, if that's why, like, if you have interventions that tend to be helpful, when you do those interventions and you make no change, now you know that maybe it is more likely the anatomy that's driving it. I mean, there's certain, if you assess enough hips, after a certain time, like, wow, this feels like such a bony end feel, no matter what you do, it doesn't change. Then maybe like the anatomy is the influence. But with this FAI stuff, I think it's over diagnosed now. I think we need to be like respectful of it. But if we're this fatalistic, like, well, you've got FAI on a radiograph, or you've got poor internal rotation on the table, we still have to try stuff. And if we're not trying stuff, then it's like, why do we even like kind of have a profession in mind?
Yeah, it's like, why would a hip surgeon or someone send someone to physical therapy first anyway, if like that's actually the true reason why they're having issues? It's like, well, we're not going to cut them open and fix it. We can do other things to improve that, which is like, I'm thinking about my case study that I wrote like years ago. And we should put that link in there too, just about like, this is some things that we did that improved this guy's squat depth. And it was pretty dramatic. It's not how it always is, but it was just an interesting case because it was such a dramatic change for someone who was told like, yeah, you should never squat deep ever again. And he like, wanted to do some sort of like military special forces thing, or it might've been like a law enforcement special group or whatever, selection process. And it's like, you need to be able to do certain things. And we were able to make some cool changes. But Trevor, what were you going to say?
Yeah, I think with the hip impingement to a certain degree is normal. When joints get to their end range position, something's going to stop it from going further, whether it is soft tissue, whether it is a bony block. Just because you experience a bony block, like you said, Doug, it's a snapshot in time, whether it's an X-ray or whether it's body weight squat during an assessment. It's one movement. So when we take one piece of information and then we try to generalize that means all of these different things, and it becomes fatalistic, that's when I think the problems occur, especially for clients, because then they do become afraid to do whatever it is. But when you can give somebody an intervention that frees up the range of motion, or they impinge later in the range of motion, then that's a good thing. Then I don't think that bony block or that cam impingement cam impingement is what is limiting the range of motion. Like we always talk about, it could be a positional issue. Their door frame could be out of alignment, and then we're going to give them some sort of intervention to realign the door frame. And if it still doesn't work, then maybe we need to oil the hinges or apply some other secondary intervention to get them to achieve their functional goals, which again, like you said, it's getting them to squat, getting them to move, getting them to be able to do what they want to do pain-free and without any sort of irritation is always our number one goal. And I think,
and like
always knowing that's a snapshot in time, regardless of whether it is like so many people, oh, I have a terrible squat, and because they do a bodyweight squat and they're not good at bodyweight squatting, but you give them an anterior load and their squat looks really good. That doesn't mean that they're bad at squatting. Maybe that strategy for them is not their best strategy to squat, and that's okay, because everybody moves differently and everybody responds to, forces or external loads differently. So it's understanding how can we give them a better strategy to do what they want to be able to do.
Yeah, that goes back to like, we're talking about FAI as like an example, but this goes for like anything. Like I'm having conversations about this stuff with patients all the time where it's like, oh, I have a bulging disc, or like I have like fraying of my supraspinatus or whatever it is. Like, it's like, yeah, like that's what shows up on the MRI or the X-ray or whatever. But like that's a snapshot, and there are things we can do to make you move differently. So that's exactly like, make it not matter. And that's a conversation I have with people all the time, is like, we're in the business of making things not matter so that you can do the things that you want to do that do matter. And that's sort of like, I don't know, the conversation I'm often having with people. Yeah, anything else you want to jump in on hip impingement?
No, like it does. I mean, it can matter, right? Like,
yeah,
it doesn't matter until it matters. And that's why if we're just going to say like, okay, people who have FAI on an X-ray shouldn't do all these things, then why are they going to physical therapy anyway? Like, what's the point? I mean, because it's like, okay, if you're that fatalistic, then you're either going to have surgery to change that anatomy, or you're going to say, okay, like, well, based on your anatomy, we're going to teach you a compensatory strategy. So maybe it is like, externally rotating your feet, but I think to assume that everybody with FAI needs to externally rotate their feet, widen their stance, all these things without trying other things first, I think is doing the patient a disservice. Because I mean, I think what it comes down to, a way to reframe the question is like, when was the last time you guys had somebody who was diagnosed with FAI, and after everything you tried, you're like, you know what? I don't think anything is going to help except you going to a surgeon and having that anatomy change. I probably had, I think, 2 people in the last like 3 years that I felt like, there's nothing I can really do to help you. If your goals are certain things, then like the only way to get the result you want is to change your anatomy. It's pretty infrequent. Like the numerator is really really low, and it's a really big denominator.
I would say
I have one person in my head that I remember him coming in, and somebody who has their hip is that far, and using the hip specifically is that far, down the road to a hip replacement or some sort of, extreme intervention. It's usually pretty obvious. Like, it's not, oh yeah, my hip hurts when I squat and bothers me a little bit. It's like, it hurts all the time. It hurts when I sit. It hurts when I do anything. It doesn't really matter what it is. And even during our orthopedic assessment, like, they have zero range of motion. I can't get them. They usually aren't limited with just flexion, adduction, internal rotation. They're limited with like everything, whether it's abduction, external rotation, extension. Nothing feels good, and they have just a serious set of symptoms that are way more than what a typical, I feel a pinch in my hip when I squat presentation is.
Yeah, and the one example I'm thinking of was a high school hockey player, and he already knew that he had a torn labrum and he had some bony changes. It was something where like he's trying to delay it and kind of push it, as far back as he can, because he sort of knew that he wouldn't be playing too much hockey, as he ages maybe. And that was something where Trevor and I both worked with him a lot throughout his entire senior, maybe junior year a little bit too, but for a while we worked with him throughout the season to sort of keep him feeling good enough to keep playing. And he did pretty well, but he wound up having to have the surgery. And that was somewhere it's like, yeah, like eventually, like this isn't just going to go away or get better, but with all of the things that we've done, we can keep you in one piece for now. But yeah, it's not very often, Doug. And yeah, I mean, that's the only one I can really think of in the last years.
Yeah, and if we're just saying that like anybody that shows up that has like poor internal rotation, we're just going to say they have a hip impingement and just throw our hands in the air. I think it's like, it's kind of lazy. I mean, pathology is a real thing. It has to be respected. And I think there's a flip side where there's people walking around like who do have like, disc herniations and nerve root compressions. And it's like, oh, we're just going to like biocycle social you out of that. Like, no, you're not. Like, that's real pathology. Yeah. But, I think that a lot of the stuff with the hip is new, but it's really not new, right? Because like the hip is pretty similar to the shoulder. And when somebody like is lacking IR on the shoulder, we don't say like, okay, we got to go have surgery for your shoulder impingement. It's like you try things to get it back. But because like this FAI stuff and the imaging, I think just is, it's a little bit more novel than some other joints. I think it has to catch up. The thought process has to catch up, but it really shouldn't be that much different than like what we do in the shoulder. And I don't think we're as fatalistic with the shoulder as we are with the hip.
It's funny because I would actually think like the opposite. I feel like the shoulder to me is more complex than the hip. I feel like there's just less stuff that can kind of move on its own in the shoulder, like the scap. It just kind of adds more complexity to it. But yeah, I mean, it's interesting. It's interesting to hear you say that. But yeah, then like there's some research that's old by now, I'm sure, that Trevor goes into in his section in our Movement Foundations course, where like just by changing the pelvic position on a table, like people were improving by like 15, I don't know the exact number off the top of my head, 15 degrees of internal rotation. Yeah. When the normal, normal might be 40. So if you can get 15 more, like that's enormous for somebody, especially if they have 0 and you give them 15, that's like a life-changing thing for some people potentially.
That's why looking at anatomy from a image, we think it's fixed, or that's kind of what has been taught to the medical community, and then to patients, is that you are this X-ray and that X-ray does not change. Versus when you look at the research or you look at just how people move, like bones and muscles and tissues and stuff are moving constantly. So I've been saying this whole time, if you're just taking a single snapshot in time and generalizing the rest of what's going to happen for them, you're doing the patient a disservice.
Yeah, so I think we kind of beat that to death, hip impingement a little bit. That's awesome. But going off of that, something we're always trying to improve with hip impingement, or typically it's internal rotation, flexion, adduction. Like those are the 3 things that tend to be, pain generators for people who have any sort of actual labrum tears, FAI, bony changes that we're trying to help people with. And that was the other topic of the other question, right? Was what are the biomechanics? What are the things that we focus on for, like, we want to improve these movements because somebody is lacking in them, right? And then comparing that to knee valgus. One of you guys want to kind of jump in and talk about how we might define knee valgus? And we're talking I'm assuming we're talking about like ACL tears in an athletic population, because that's 95% of the time what people care most about with knee valgus, but take it wherever you want to go with it.
For me, knee valgus is a true frontal plane and rotational torque at the knee. It's not just kind of the way it looks, where people think if the knee is inside of the hip, that is knee valgus, when that's not necessarily always the case. So if we go into those motions that this question was asked of hip internal rotation, which goes along with hip flexion and adduction, knee flexion, and then ankle dorsiflexion and foot pronation, that's just a position of loading. And if you're missing range of motion at one of those joints, and usually it'll be hip flexion or ankle dorsiflexion, then the knee is kind of stuck in the middle and has to compensate for some sort of force that's not being able to be handled or distributed to the ankle or to the hip. So that's when we see that, typical like knee abduction with tibial external rotation and femoral internal rotation, which causes that like medial force and rotation that we see people have all the time with an actual ACL tear. So kind of globally, it's like we want to make sure people have hip flexion, adduction, and internal rotation, which is why what we were talking about before with the hip impingement, when the hip is in a position that limits hip internal rotation, that's something that we want to make sure people can control and aren't always relying on or using a strategy that limits hip internal rotation, which is that over back extension, anterior pelvic tilt, all that kind of stuff that we go into. But I think like the knee being inside of the hip, which may look like valgus, is a normal thing. So if we look at somebody who's in a single leg stance pattern, to be able to stand on one leg, your foot has to be underneath your hip, has to be underneath the center of mass, which means our pelvis has to rotate, our knee has to come in a little bit, and we're keeping the foot underneath the knee, which is typically inside of the hip. So that may look like valgus kind of statically, but it's not actual valgus. That's just a little bit of hip internal rotation at the pelvis as we're rotating in the closed chain, along with a little bit of knee flexion and ankle dorsiflexion and foot pronation.
So it's like if you take up.
Yeah, exactly. If you aren't using the range of motion and able to get it in other places, that's when we see now knee valgus as a compensation usually.
Right. So if you're going to go shift your weight over to one side in an athletic movement, let's say, and let's say you're lacking hip internal rotation, which you kind of need to get yourself over to that side. Let's say you have 5 degrees of it, and like you're required to have 15 or whatever. Who cares what the numbers really are? It's almost like you're impinging, so to speak, at the hip, and you're taking up all of the range you might have there. So then you're going to have to find another way to get your knee underneath your center of mass. And the next best thing might be to just gap the medial part of your knee to actually drive your knee inward, which would be what we're talking about it as like the knee valgus position, or like the knee valgus, another death sentence, right? Like you can't have any knee valgus. And then even going back to like squatting, that was also part of the question too, was even just talking about like gym movements, right? Like, because that's something where, if you look at somebody squat, you're not necessarily seeing them, like their knee's not coming into the middle of their body. And that's something that we're trying to do. We're not having people squatting with their knees driving in towards each other. So maybe Doug, do you want to just talk about that? Taking a more, gym centric exercise and why we're still chasing internal rotation, adduction, flexion.
And first let me just piggyback on what Trevor said about cutting. So there's no movement that's like inherently bad or good. I mean, we often hear things like internal rotation of the hip is bad, pronation of the foot is bad, but we want to avoid extremes. Like if you had no pronation at the foot or no internal rotation at the hip, like you wouldn't be able to change direction. You wouldn't be able to load and absorb force. So like if you look at the foot, like a little bit of pronation is good because it acts as a shock absorber. It helps to create kind of like an elastic component at the foot, so that now when you go to supinate, you've got this elastic component and this sort of transfer of elastic energy. The problem is if you pronate so much that now you're like in this you overly absorb to the point that you can't generate propulsive force. Now you're, you create like an instability. Same thing with the hip, right? Like if you have so much internal rotation that now you're lacking stability, and now where's your body going to find stability if you have too much internal rotation? You might try to find it by pronating too much at the foot. You might try to find it by, generating too much torsion at the knee. And that's where you get in trouble with at the knee and with ACLs, is like when you lose stability. Right now instead of having this active motor control, now you're at the last line of defense, which is your ligament, your joint. And when that fails, then your joint fails, and then you're in the operating room. So we need internal rotation at the hip. We need pronation at the foot. We just don't want to have so much of it that now we have a lack of stability, because if we absorb so much force that like now how do we generate propulsion if we have to get into these end range positions at any joint, whether it's the foot or the knee, to try to create stability and get out of these bad positions, then we're in trouble. But we need internal rotation. And if you don't have authentic internal rotation, if that range of motion is not available to you, like if you have none, then where do you get that? How do you absorb force? You have to get it from somewhere else, like Trevor said. So, and it's one of those things where, I don't actually, if you ask me the technical definition of valgus, I'd probably get it wrong. Someone's going to look at a research paper and tell me that it's wrong, but you know what a good position is when you see it. And if you look at like somebody cutting or changing direction, there's always some internal rotation, but where it looks bad is when you look at that knee and it looks like there's torsion at the knee, there's a ton of pronation at the foot, where even in a snapshot, you're like, this person is at such an end range position. I don't know how they're going to get out of that without doing something weird. And that weird thing is usually putting a joint at risk. So that's kind of like, the valgus, propulsion, loading to explode kind of a thing. You need to have all these things and be able to control it. With regard to squatting, like you said, Greg, I don't think that we're visibly observing internal rotation in a squat, but I think the ability to internally rotate is reflective of the hip health that's necessary to squat. So if somebody, typically people who like have terrible internal rotation can't squat well, or if they can, you're wondering how they get it. And the ability to internally rotate and flex is reflective of a hip capsule that where you can get, posterior translation of the femur, which is going to prevent some of that impingement when you get into deep hip flexion. So we don't expect to observe, at least observe a ton of internal rotation during a deep squat, but typically people who have internal rotation available are able to get into that position, at least at the hip. And then assuming that things, they have the flexion at the ankle and the knee, they can get a deep squat. But we want somebody to have that internal rotation available, because then they're more likely to squat without some kind of a compensatory strategy like impingement.
Right. So it's like the movements that you need to get into a squat that are happening at the femoral head. You want it to be able to slide posteriorly, you want it to be able to rotate, and those things go together. So those are things that we're trying to improve, maybe with some of our table movements, or giving somebody a stretch or some sort of lower level exercise to kind of give them access to those positions where they can do it then on the table, but then they're not going to go and go to end range internal rotation while they squat. It's just giving them space in the back of their hip to get into a deep hip flexed position. Yep. And then that just makes me think about, talking about FAI, and you had, Doug, spoken about recently the whole don't translate your knees forward past your toes when you squat thing, and how common that is. And it's like, if somebody's told that and they go and squat, one compensatory strategy is just to arch your back, and then you've got hip impingement. So it's like, pick your poison. Do you want to load your knee, or do you want to, create some hip pathology? And we've had patients before where, they come in and they've been told that with good intention, but you just take that coaching cue away and all of a sudden their hip feels good. And it's like, all right, so you just need to do things a little bit differently.
And that's a great point. That's why I think the rock back test is kind of a waste of time, because first of all, you're not weight bearing, you're not on your feet. And your knees can't actually go forward when you're in a rock back test because they're in contact with the ground. So it's almost like, okay, we're squatting with a vertical tibia. And if you squat with a vertical tibia, it's more likely you're going to have to go into an anterior tilt to maintain your balance. And then we know from the research paper you referenced that Trevor has in his portion of the course, that now you're going to lose internal rotation and flexion, and you're more likely, the mechanism a lot of times for hip impingement is the inability to get out of this anterior tilt and to control it. And just getting somebody into a posterior tilt allows people to get more hip flexion, more internal rotation. And how do you get a posterior tilt? You bring your knees forward. So even without making any change at the hip, if you have somebody squat and let their knees go forward, you might reduce some of the impingement. So that it wasn't always the pathology that was preventing that deep squat. Like, how are you squatting?
Right. Just don't lecture them on flying if they don't lecture those birds.
Because that question asked about the cueing for those different things too, right, Greg?
Let me pull it up real quick. I think it said, I'd be interested to hear more about the biomechanics surrounding the need for femoral interrotation during squatting, jumping, cutting, differentiating, and cueing for those movements versus unwanted knee valgus.
I think so much of it from a cueing standpoint is not cueing and just putting them in positions where we're going to elicit the movement and the strategy that we want, which is why we always choose from a squatting standpoint an anterior load versus a back squat for 99.9% of our people. Because again, it takes away the need for us to coach and helps them get into a position where they're going to use a better strategy that's getting them to distribute stress over multiple joints. I think we would all agree, anything that is going to be relatively high force or high load, we want people distributing the force and the stress of that over multiple joints. So if we're telling people to not let their knees go forward, then we're limiting how much they can use their ankles, how much they can use their knees, so how much can they use their calves and their quads. And same thing with, so many athletes are taught when they're playing defense in sports and they're going to be in an athletic position to keep their chest up, where their strategy to keep their chest up, well, there's two cues. It's either keep your chest up or get on your toes so their heels are off the ground. So both of those strategies kind of limit what they have access to, and it's going to make them use what we've been talking about this entire time of that more of an anterior pelvic tilt back extension strategy, where they're not going to have access to good ranges of motion that they need for the different movements that they're going to be able to do.
And then I was just going to say, I'll let you go, Doug.
I was going to say, sometimes it's more about what you don't say. Like if you tell somebody when they squat to, big arch, stick your chest out, you're going to make it, like if I was thinking all right, what cue would I use to try to encourage a hip impingement? It would probably be that.
Yes. Put your shoulders together.
It's probably the number one cue.
Chest out.
Now, and we're talking about in a clinical population, athletes who use a squat as a means to an end of the field. I'm not talking like if you want to squat 1,000 pounds, like kind of disregard what we're saying, because then it's about like that's about performance. You're willing to take a little bit like compromise health to achieve that, to put more weight on the bar. But from like if you're just squatting as a way to strengthen your legs for sports, I wouldn't use the cube chest out.
Right. That was actually what I was going to start talking about. Go ahead, Trevor. Go ahead.
No, I was gonna say, like, there's so many cues like that, just like the don't let your knees cave in thing that we give as the teaching cue, not as a cue to fix something that causes the problem. So instead of just giving somebody a weight and telling them to squat or sit down and stand up or whatever kind of just basic overall things, we teach them how to, or we're trying to teach them how to do it before they even try to learn how to do it themselves. So it's the same thing with like the knees in. It's like, I agree. If I don't want somebody's knees touching when they're squatting, but if they're squatting and their knees are just going forward, don't cue their knees. Let them just keep doing what they're doing. But instead, people say, keep your knees out. So people who have their knees straight ahead then start trying to drive their knees out as far as they can. People who are squatting with a good back position start arching their back as hard as they can because that's just what they've been told to do. So they've been taught to chest out. Because if I see somebody folding in their squat and their chest is parallel to the ground, I'm going to tell them to keep their chest up. It's not a bad cue, but that's not the cue we give to everyone all the time.
Right. And then that was what I was going to go into with Doug was like, I don't work too often with power lifters. It's pretty infrequent with where I'm at. You probably see more power lifters than Trevor and I. And that's probably, maybe a conversation that they have to kind of have with you is like, okay, well, my sport requires me to keep a vertical tibia as much as I can and just try and, hit that point and then get back up. And I'm doing this with such maximal loads. Like, how do you talk to a power lifter about the stuff that we're talking about right now?
Well, I mean, it's easier to get buy-in when they see me because usually it's because like something hurts. But, I work with some power lifters who are like really, really competitive in their weight class. I don't generally try to change their squat.
Right.
Like, this is what you do. This is what you enjoy doing. But I give them things to do that when they're not squat, like I want them to have a different strategy. I mean, we could start with like, how do they test on the table? Because if they're missing key ranges of motion on the table, now they don't have the option to squat a different way. Right. People talk about like self-organization, like maybe they're squatting a certain way because they have like negative hip internal rotation. If I get them to 5 degrees or 10 degrees or even 0 degrees, they might not even think about changing their squat, but they'll feel better just because they have more range of motion in their hip available to them. So I want to make sure that they have the raw materials to squat, and the raw materials for a power lifter are much different. My expectations are much lower than what they would be for like a field sport athlete. Like I don't want you to have like negative internal rotation. I want, I don't want you don't need to have 40, but if you have like 0, maybe if I get you to 10, like we're doing a little bit better. So we'll start with like, do they have the raw materials? And then especially if they're competitive, I'm not going to try to change their squat, but I might say like, look, as an accessory movement, maybe do like a 2 kettlebell front squat or a Zercher squat, because a lot of these athletes, these lifters are doing like, accessory movements where they're like squatting and doing like, they're trying to get more volume. And I'm like, look, excuse me, maybe when you're trying to get more volume, use a different squat just so that you're stressing your hip in a different way. You're not in as much of an anterior tilt. You're getting to a different depth to preserve your hip health. And then they might even say, okay, like all you ever do is like sagittal plane, like maximal effort squatting, like just like once or twice a week, add a single leg movement, So I'm giving them a little bit of variety. They're going to do accessory work anyway. I might try to give them accessory work in a single leg exercise, or maybe that's not as sagittally dominant. And hopefully that gives them enough kind of bandwidth, because specialization, I think, is like, that's where you get in trouble from a health standpoint. If like you're so adapted to do one thing well, it's what helps you perform at a high level. But if you get to the point where you just can't do anything else, now your bandwidth from like a health standpoint is very low. So if we can expand that bandwidth, like not a lot, a little bit, maybe allow them to compete without as many symptoms, without having to change their squat, because that's generally the last thing I'd ever want to do with somebody who's competitive.
I always wonder with something like that and not necessarily just powerlifting in general, but just, with, I guess powerlifting is a good example of it, where is the strategy in the position, meaning the feet width, feet turnout, all that different kind of stuff? Is that the strategy that they were taught by their coach because that's what their coach has just kind of been taught how to do? Or is that the strategy that actually works best for that person based upon their mobility and range of motion and, actual physical constraints and strengths? So that's always just something I think about. That's, just an interesting, like almost rebuttal to that, is that person actually using a strategy that is best for them? Because again, like so many people don't have that much hip abduction, but they're taught to squat in this crazy wide stance that limits how much they actually have to go down. But maybe if they tighten their feet up, not inside their hips, but just 2 inches on each foot, that can make their hip pain go away, and they can still keep their big squat numbers.
Yeah, and it's like, why do people like arch their back in a bench press to reduce the travel, the distance of the bar path? Like with a wider squat, you don't really have to squat as low to hit your depth. The bar isn't moving as much. But I think it's a great question. I would look at, I think it's both. I think like if you look at the world record holders in a squat, it's unlikely that they have this really terrible strategy. They're only doing it because their coach told them. Right. So like I think the best squatters in the world, from not from like a aesthetic standpoint, from like a weight standpoint, they are squatting wide. So there's something to it. And so, there's a reason why, like, if you want to set the world record in the squat, you're not going to have like a narrow stance and do a front squat. So I think it is both. We have to dig deeper and figure out, like, all right, like you said, maybe they're going wide, but if they're always hurt, if they brought their stance in an inch, would they feel better without compromising the weight that they could put up? And that's where the trial and error kind of comes in. Like the last thing I want to do, like I said, is change that stance if they're successful. But if you're always hurt, then you're not successful because you can't compete.
Yeah, so, I think that's a good point. I mean, you said that when you first started this, was they're coming to us for pain initially, which kind of almost changes the entire ballgame. It's not like they're coming in and like, hey, I feel great. I'm just trying to optimize my movement, and my knee bothers me every now and then or something. So we're doing more maintenance stuff to keep them healthy. If they are injured and are not healthy and cannot compete, then maybe we do have to not necessarily completely, reteach their squat or anything like that, but maybe we are looking a little bit more at the strategy that they are choosing and seeing if there is some little small tweak that can make a big difference for them. That's not completely, starting from scratch.
Awesome. Anything else you guys want to throw in there for hip impingement or knee valgus?
I think it's like, you just don't know until you try stuff. It's hard to say, like, if you see this, you should do this, because there's so many variables that can influence. Like, you might not have to change someone's squat stance, or you might try everything, and the only thing that makes them asymptomatic is to narrow the stance or turn their feet out more, whatever. It's like, performance is important, but like I said, if you can't compete, then it doesn't matter like how well you perform when you're healthy if you're going to miss your competition. So like, what do they say? Like, availability is the best ability. Yeah. It's kind of true. But it's a fine line, because, then if you have too much bandwidth, then you're not going to be good at your sport. And powerlifting is a very specialized sport. So yeah.
Yeah. Awesome.
Cool.
I think that's good. I think that wraps up Keep It Real number 5. Perfect. That's all we got. Hopefully we see you guys again soon.
Thanks, everybody.
Thank you. Thank you for listening to the Resilient Performance Podcast. As a thank you for listening, we'd like to offer a 10% discount on our online products, which you can find at resilientperformance.com. We'd like you to use the promo code PODCAST, PODCAST, to get the 10% off. Right now we have the Resilient Movement Foundations course online format for you to purchase there. And we hope to grow that soon before the end of the year and have some other offerings. We hope you enjoy. Again, that's promo code PODCAST, PODCAST, for 10% off. Thanks.